Job is to introduce Associate Professor Sandy Schultz and his star-studded team from Monash Trauma Group. So please enjoy the sessions. Welcome, Sandy.
All right. Do both of these mics work? All right. Well, first, thank you to the organizers for the opportunity to come and present our research to you today, and thank you for attending. Before we get to the talks, I just wanted to do two brief things. Firstly, acknowledge that this research program that we've undertaken the past 5 years has certainly involved a lot of people and contributions, so I want to acknowledge and thank them from the beginning. And then the second thing I wanted to do was, before we get to the talks, is give a broad overview of some of the research program's key objectives, and also the research study design, just so we don't have repetition throughout. So everything I'm about to say will generally apply to all of the talks. So when we started the program back in 2017, there were a few key knowledge gaps that we wanted to set out to address. First, at the time, and even still now, thank you. And still now, the diagnosis of concussion relied heavily on self-reported subjective symptoms and even signs that aren't always clear. And so obviously a lot of concern about whether or not concussions are being reliably diagnosed. And so the first objective of our program was to try to identify more objective and reliable ways to diagnose a sports-related concussion. After someone's had a concussion, one of the next important clinical decisions is when have they recovered and it's safe for them to return to play. So again, a heavy reliance on self-reported symptoms, which are subjective. And even at the time, there was evidence emerging that symptomatic status didn't always equate to neurobiological status. So people could be asymptomatic but still be showing biological changes that hadn't recovered. So again, we wanted to find whether or not there were objective ways to monitor recovery and help facilitate those return to play decisions. At the time in North America, there was certainly mounting and emerging evidence associating a history of concussion and participation in collision sport with long-term neurological abnormalities. But in Australia at the time, there was still a lot of debate about whether or not these findings could be generalized to athletes coming from popular Australian sports. So we wanted to start to provide some insight into that. And then lastly, whether or not the male and female brain respond differently to a concussion. And so again, little known at the time, and we thought that Australian rules football was quite unique internationally in the sense that you have both men and women playing the same collision sport under the same collision rules. And so we thought we'd take the most of that opportunity and start providing some answers there. So we partnered with some amateur football clubs in the Victorian Amateur Football Association, and nearly all of the players involved consented to participate. And what we did was in the preseason, we did baseline measures using those common self-reported tools such as the SCAT. We also collected some blood so we could look at blood biomarkers. We did some cognitive and ocular motor testing, and then also did neuroimaging with MRI. Then over the course of the season, if they did sustain a concussion, we'd follow them up at acute and subacute recovery times. So within the first 48 hours, again at 1 week, and then at 2 weeks. And what was nice with this study design, and I guess in collaboration with the teams and the clinicians, we looked over the evidence at the time, and they actually agreed to make a mandatory 2-week recovery time, even though it was 2017. And so that, as scientists, gave us this nice clear study period where we could monitor these biomarkers without them being affected by the athletes coming to return to play and sustaining more injuries during our study time. So, looking at this, after the concussion, obviously this was helping us fill those knowledge gaps regarding diagnosis and recovery. And then in terms of the potential chronic impact, what we did at baseline was we also collected information about their concussion history, how long they'd been playing collision sport, and then we could associate our baseline measures to that historical data and see how they related. Oh, and the other thing I'll point out is we started with men's teams, and then over the years we had women's teams join. So as we go through the talks, you'll see that we have more men participants, and that's why. So we've had to reshuffle the speakers just because one of the original speakers wasn't able to make it. So I'm going to present first, and I'll present on MRI biomarkers, particularly related to diagnosis and recovery, so in that acute and subacute time. Then I will hand things over to Stuart McDonald, who will talk about the blood biomarker work in that same time frame. Then Georgia Fuller-Simons will present some of her PhD work, which is focused on using cognitive ocular motor tasks in both the acute and subacute time point, and then also transition into some of those chronic or potential chronic impacts. And then we'll conclude with Meng La, who will focus on the use of neuroimaging in the chronic context of mild TBI, both some of our previous work and then some more exciting new advances he's been making. So with that, we'll start our first talk. So the first thing I want to point out, so we'll focus on the acute and subacute, but you'll notice that we didn't have a 1 week time point for the MRI analysis. We found out early on that the participants weren't too keen to come back and do 3 MRI scans over a 2 week time, so we ended up removing that one and just focusing on the most acute and then the one closest to when they were returning to play. And so when we put this symposium in a few years ago, this hadn't been published yet, but it has just been recently published now, and I'll point out that the first author is David Wright, who's an imaging expert also at Monash. So this will give you an idea of just the demographics of the participants, and again, this can be applied to all the talks today. So we're looking at kind of early to mid-20s. Years of education are similar across all the groups in males and females. The males were different in terms of weight and height, which could be expected. And then the other thing that the men and women differed on was the amount of, or their previous years of collision sport played and their concussion history, with the males reporting a higher incidence of both. But in terms of within the sexes, the controls versus the concussed, there were no differences on those groups. And then I'll also point out that the control group in this study were Australian rules footballers. They just hadn't had a concussion in the past 6 months. Before we get into the MRI, I just wanted to quickly go over what we found in terms of the self-reported symptoms. This is pretty consistent with what you see across the literature. In a nutshell, both the males and females do show abnormalities on this on the SCAT test, depending on the measure you look at. These measures or these abnormalities are present at the 48-hour time point, but we didn't see any differences at a group level when we looked at their 6-day and 13-day compared to their baseline. So at a group level on these measures, they weren't significantly different from a baseline by 6 days. When we look at our MRI findings, so this is looking at diffusion-weighted MRI. And so essentially this is looking at the dispersion of water molecules in the brain, and these measures are often used to reflect white matter integrity. So this is a common measure, fractional anisotropy, and the areas highlighted there in the red and the blues, that's indicating differences between the concussed individuals and the control group. So you can see in the corpus callosum, we see differences between those groups at 2 days. And we're still seeing those differences at 13 days post-injury, albeit they do start, or they do appear to be resolving at 13 days, but still a significant difference between the control group and the SRC at 13 days post-injury. This is another diffusion tensor imaging measure, radial diffusivity, and again showing similar similar differences between the groups. So quite robust differences at the 2-day time point between the controls and concussed. Again, there may be some resolution occurring by 13 days, but there's still that difference present. And this is a slightly different diffusion-weighted imaging methodology. It's a pixel-based analysis, but basically just showing commonality across these measures. Again, differences in the corpus callosum that are quite robust at 2 days and still present at 13 days post-injury. In terms of potential sex differences, so this is on the same measure, fiber density. So this is comparing the concussed men versus the concussed women. And what we're seeing is, I guess, more significant change in the male brains compared to the female brains. And again, this is quite obvious at the 2-day time point, but resolving but still present at 13 days. So, to wrap things up, in terms of the SCAT self-report measures, we do see changes at 48 hours. These have resolved by 6 days. On the other hand, when we look at our diffusion MRI results, we are seeing changes at 48 hours, but they're remaining present at that 13-day recovery time point. And so our evidence is indicating that these white matter abnormalities are persisting beyond the resolution of those self-reported symptoms. The differences were more pronounced at 48 hours than 13 days, but again, they were still there at 13 days. There are questions still left to be answered in terms of what's actually happening in the brain that drive these changes related to white matter differences, and we're doing some animal model work that we hope can provide insight into that. And again, I've just focused on diffusion MRI today, but there are other MRI modalities that can provide additional insights into other pathophysiologies, and Meng will touch on some of those when he presents the chronic findings later on. We did see some subtle sex differences between the men and women that were concussed. With that said, I guess do want to emphasize that we did have very low group sizes for the women, and so that's something that we want to validate in a larger study. And again, we have the tools with animal modeling to further explore how or why that might be the case. And so overall, while our results and others from around the world do indicate that MRI can identify changes both acutely and may be useful in measuring recovery, there are some practical issues in terms of everyone being able to access an MRI and using it in this manner. And so it raises the question of whether there are more applicable and readily available biomarkers that could be used. And so with that, I'm going to segue over to Dr. Stuart McDonald, who will discuss some blood biomarkers.
Thanks, Sandy, and thank you to the organisers for having us. So, yeah, as Sandy mentioned, I want to talk a bit about the work we're doing on blood-based biomarkers of concussion, both in the context of diagnosis, but also for monitoring recovery. So, there are a number of different potential candidates for fluid-based biomarkers of traumatic brain injury, and some of the ones that we and some other groups have focused on are proteins that are found in cells in the brain, so proteins that are particularly abundant in the brain, and normally you find them sort of at low levels in the circulation, but when there's a brain injury, some of these proteins can come out and reach the peripheral blood, and fortunately we've had some technological advances the last few years that have meant we can actually measure these proteins with high accuracy and high sensitivity in peripheral circulation. So this Simoa technology is one we use quite a lot, and it's really enabled some insights that we weren't able to do previously. So at the time when we started this, and still to an extent now, we didn't really understand the true utility of these biomarkers in the context of sports-related concussion specifically, so on the mild end of the TBI spectrum. And some of the sort of key areas that we thought these might be able to use for, and we didn't really know at that point, was in assisting diagnosis once we have a diagnosis, and predicting those who will and who will not recover as well. And then finally, as Sandy mentioned, this important question around when it's safe to return to play. So the first study I'll present to you we published this last year in biomarker research. So if you'd like to have a look at the full detail, the full results set that's in that publication. The first set of results I'll show is a protein called neurofilament light. So this is found in axons. And what we can see here is we have a control group on the first column there, which is all non-concussed male players during the pre-season. And then in the circles, we have players who sustained a concussion both at baseline, so pre-injury, and then 2, 6, and 13 days post-injury. And what you can see there, the controls and the baseline, they cluster quite nicely in that sort of 5 picogram per mil range. But once there's a concussion in most of the players, you get this continual rise over this period. And we thought this was quite striking, and I'll come back to sort of the implications of that later. For another axonal protein called tau, we saw a similar but less striking result where we had elevated levels in males at 13 days. GFAP, which is found in astrocytes, so another cell type in the brain, we found there was elevated levels at 2 days in male players compared to their own baseline, but not compared to controls. And as I'll show you later on, we've since worked out that at this 2-day time point, we're probably measuring it a little bit too late for this particular biomarker. And then when we look at how these together performed or individually performed as diagnostic biomarkers using these area under the curve analyses, looking at the combination of sensitivity and specificity, you can see that at 2 days, our NFL had a good ability to separate our concussed and non-concussed players with an area under the curve of 0.73, whereas its peak performance was actually at 6 days, so 0.85, which is in the diagnostic space is considered excellent. And then drops off slightly at 13 days, but still quite good at 0.79. So you might have noticed that I mentioned those results in males, and that was in males, 20 males were concussed in that study. We did also have 8 females, and when you put the data here, you can see that actually we didn't see any such changes in the females. And we also didn't see any change in UCHL1, which is another protein found in the neuronal soma, and we'll come back to that a bit later. So in terms of what the major findings here and discussion of sort of this potential sex difference, the major implication we had found was that we have this prolonged elevation in serum neurofilament light levels. So these NFL levels are up for a prolonged period, and in terms of a diagnostic, that has advantages in that you can measure it at quite a prolonged period post-injury, and it potentially assists the identification of an injury. We saw quite strikingly that the levels of this protein continued to rise throughout this 13-day period. So actually not just from 2 to 6 days, but continuing on to 13 days. So what this suggests to us was that there's either ongoing axonal injury. We know more and more now that traumatic brain injury isn't just an event. There can be secondary pathology that causes further damage after the injury. So what we think this might be occurring in these cases, or potentially a combination, there's this ongoing clearance of these damaged neurofilaments from the brain. And either way, when we consider that pretty much all of these players return to play at this 2-week period, if they do have this unresolved pathology, then that obviously raises some concerns around return to play. So at this point we have some key unknowns, and some of them I'll touch about, some other research we've done since then. Obviously 2 days is not ideal from a diagnostic perspective. Often you would like to see a marker that you can also use in this sort of acute setting. So can we use biomarkers more acutely to assist diagnosis? The lack of changes we saw in females, is this a true biological difference, or is it just a reflection of a small sample size we had here, and potentially we just had a sample that didn't have the level of injury severity that their male counterparts did? And obviously looking beyond 13 days. So we see these changes persisting out to 13 days, well beyond the symptoms. When do they come back to normal? So at the same time we ran that study, we also had a study we partnered with Race in Victoria looking at professional male and female flat track jockeys, and jockeys are at high risk of concussion due to falls. And what we looked at, and I'll just show some of the data, we just published this a few days ago in the Journal of Neurotrauma, but we saw when we're looking at these particular blood biomarkers, we have neurofilament light here. We can see we had elevated levels at 7 days. So a similar study design here, we went out to 1 month and 12 months for the final 2 time points. So we had elevated levels at 7 days and at 30 days. And you can see that both with the group level data up the top with the box plots, and then with the spaghetti plots down the bottom showing the individual trajectories over time. And you can see when you look at both of those that most athletes of these 15 concussed jockeys their NFL levels returned to normal by 12 months, but for a couple you can see there in the red and orange, or potentially you can see it, that remained elevated. So we're starting to see this sort of diversity or heterogeneity in the pathology, which shouldn't be surprising given we know that it's clinically it's quite diverse as well. GFAP, we saw a similar trend before where we get elevated levels in some of the jockeys at 2 days, but in some we don't. So now I wanted to sort of finish talking about some of our ongoing studies and how we're trying to sort of really fine-tune how and when we can use these blood biomarkers to best assist diagnosis and management. So we've got a study running through the Alfred Hospital Emergency Department where we have CT negative mild TBI patients, some of which have sports-related concussion, but others are coming in for different reasons. And we actually get them firstly, within typically 2 to 3 hours post-injury. So they're all within 6 hours here. And we look at these 3 proteins found in neurons and astrocytes. You can see the 2 things that stand out to me when you look at GFAP and UCHR1 is firstly that there's very little overlap between the controls and the concussed patients. But also, when you consider this as a log scale, there's quite a significant heterogeneity there. So you can have people with concussion with levels of GFAP, for example, that are around 100, where most are, but then there's quite a few that are well into the thousands and up to 10,000. So it's clearly a heterogeneous population. UCHR1, same sort of thing. NFL, again, we don't really see too much acutely, but we get this delayed increase. So at 7 days, in most of these patients, we're getting elevated levels. We're also interested in some other biomarkers. So interleukin-6 is an inflammatory cytokine which is associated with inflammation. And we can see here that we're quite sort of taken back by its ability to separate the control and concussed patients here where there's very little overlap as well. When we look at these again as how they perform as diagnostics, the 2 key things I want to point out here is firstly that when combined, all of these biomarkers at 0 to 6 hours have a really good area under the curve of 0.93. Most of that's made up by IL-6 and GFAP. And at 7 days, slightly less, but still really good, 0.85. And most of that's made up with NFL, which has an area under the curve of 0.84. What I also wanted to show with this data is that this sort of question about a sex difference, we're starting to get some ideas from this data set. We've got a bigger sample of females, and basically the take-home message is for these particular proteins in this cohort, we don't really see any differences between males and females. Finally, I wanted to talk about a big sports-related concussion program that we've launched last year. So we've been fortunate to expand our partnership with the VAFA to include over 70 teams now, male and female teams, and we're really trying to use this partnership to do our best to answer some of these big questions around return to play. And so we have sort of this growing information about how we've got this diagnostic utility and we understand more of this temporal profile of NFL and GFAP in concussion, but there's lots of unknowns that remain, so including how these profiles evolve over time and ultimately how we can use them in management. So our aim here is to create the most comprehensive profile of these proteins after concussion to date, and then to analyse these trajectories, so how these profiles evolve over time and what that looks like typically, but also atypically, and what different classes of trajectories can we identify. We started last year. Unfortunately, the footy season was cut short by COVID, but the recruitment's going really well for this study, and we are on track to reach our recruitment target of 100 concussions and 60 controls, and we're actually visiting each of these players after their concussion at 8 different time points, and we do that with home visits, and we've got a really really excited about sort of this internationally unique database we're building here, not just in terms of the proteins we're interested in now, but also for creating this biobank that we can look at for other potential candidates in future. And in addition to taking a blood sample, we also get an assessment of their symptoms, and they sit a cognitive test in Cogstate. So I wanted to show some of the initial results we've got from last year. So this is 35 concussions, I believe. So this is unpublished data, and we're really sort of, we'll need to get to the full sample size to really get the full insights we want to. But what I wanted to show at this point is two of the proteins we're looking at, GFAP, what we're actually seeing with these individual trajectories. So at a group level on the left, you can see this is a log transformed data. You've got this really pronounced peak of GFAP at 24 hours. So we've brought this assessment point forward to 24 hours, and we see it's much more pronounced at this stage compared to 48 hours in the previous study. And also what we're seeing there at a group level, you can see there's potentially this secondary peak occurring at 29 days, and we're interested to see sort of whether that holds true and what that might actually mean. When we look at the individual plots, which is really where it gets interesting, is you can see, firstly, pretty much all of them have this rapid rise, but the extent of that varies between cases. They mostly return down to around control levels, which I haven't shown the controls here, there's too many lines otherwise. But yeah, you can see quite clearly some of these cases actually have this secondary peak. So we'll be interested to see, how this evolves with the full data set. And for neurofilament light, we see again this peak that seems to occur around 1 to 2 weeks at a group level, and then it's resolving back down towards normal levels by 3 to 6 months. And for the individual plots, again, you can see this heterogeneity, but what I'm finding really interesting here is sort of not just in terms of the magnitude here, but the shape of these profiles. So individuals vary in terms of their timing of the peak and also the rate of decline. So I think, as I said before, clearly this is a heterogeneous condition, and perhaps in these biomarkers we actually have a really good tool for detecting this variability and therefore tracking individual profiles over time. So we're really excited to see how this goes, and hopefully we'll share the full data set in a publication and at a future conference. So just some take-home messages from what we've shown from the blood biomarker perspective. So our work, not just with blood biomarkers, but also with this advanced MRI, is really challenging the dogma that sports-related concussion is just a functional injury. We just didn't have the tools that are available to actually detect these microstructural damage that does occur in many cases, or in most cases. In terms of the two main biomarkers I focused on today, GFAP for astrocyte pathology and NFL for axonal injury, we see that it's elevated in most cases of concussion. When combined, they have a prolonged diagnostic window, so GFAP useful in that acute stages, and when we get out to the days and weeks following injury, NFL goes up and has utility at those points. And what we're really interested in is, we think that these might be useful at an individual level, being able to track this neuropathological recovery and inform return to play decisions on an individual basis rather than just coming up with an arbitrary time point. So basically what we're trying to do here is come up with a neuropathological basis for concussion management. And I think the MRI work and the blood biomarker work that we're doing, as well as other groups around the world, I think we're getting to the point where soon we'll be able to actually use these as a clinical tool. But the next step from here is working out exactly how and what biomarkers we can use in what combination to really best sort of fine-tune how we're going to implement them into clinical practice. So with that, I'll finish up and pass it on to Georgia Simons.
Thanks, Stu. I'm Georgia, and I'm going to be talking about some oculomotor assessment in this cohort of Australian rules footballers. So firstly, some background on the oculomotor system. It's a highly ramified neural network involved in the generation of eye movements such as saccades. So saccades are rapid eye movements, something that you would make to a peripheral stimulus in your peripheral vision. So the oculomotor system is highly well characterised, probably one of the best characterised sensory systems. It's highly accurate and non-invasive, and therefore it is a excellent biomarker that we can use in this space to investigate cognitive function. So the system involved in oculomotor function, through this diagram we can see it involves like a number of cortical and subcortical brain regions, and cognitive processes are known to influence saccades, these type of eye movements that we're interested in. And so various cognitive processes such as attention and memory are known to influence the generation of saccades. Because this system is so highly ramified, these networks are vulnerable to mild brain injury such as concussion and sports-related concussion. So we can use specific saccade tasks to investigate cognitive function in this group. So I'll take you through a few of the saccade tasks that we did use. Firstly is a prosaccade, which is an eye movement to a suddenly appearing target, and it's a measure of basic oculomotor processing. So a participant would be looking at a central green cross, and a peripheral cross would then flash, and the participant would be required to accurately make an eye movement to that location. The next task is the antisaccade task. So it's an eye movement to a mirror opposite location and is a measure of cognitive processing speed and inhibitory control. You'd be looking in the centre and a cross would again flash in the periphery, but instead with this task you'd be required to approximate a eye movement to the mirror opposite location to where that target flashed. So it's a bit harder for the participant. And then finally we looked at a memory-guided saccade task, which is an eye movement to a remembered location and used to measure inhibitory control and working memory. You'd be looking in the centre and briefly a red peripheral cross would flash, and without looking at it you'd be required to remember that spatial location using your peripheral vision. Once that central cross disappears, again approximating that location. So in terms of the analysis, when we look at the eye movements, this is just sort of a sample plot of what I'd look at when analysing this. So the green line is representing that central green cross. It's at central fixation or 0 degrees from centre. So at that first point when it's in the centre. When that cross jumps to the peripheral, you see that it jumps up to 10 degrees away from centre, and this is what a sample eye plot would look like. So you can notice that there is a delay from when that cross jumps to the processing speed for the individual, and that's the time taken to generate that eye movement, and we term that latency. Then we also look at the amplitude of the eye movement, and we can get a measure of visual spatial accuracy. So essentially that is where the person is looking over where they should be looking, and then that's a measure gain that we look at. And then you can also look at errors in the various different tasks. So just to go back to Sandy's key knowledge gaps, with my acute study that I'll talk about, this was really looking at oculomotor assessment to look at diagnosis and particularly return to play. And then my chronic study I'll talk about was investigating cognitive function as a long-term neurological consequence using oculomotor assessment. So firstly, to this acute study. Over the essentially large program that we collected, we had 139 oculomotor baselines, and subsequently 18 participants that sustained a sports-related concussion were re-recruited at 3 time points post their injury and repeated that same testing with those 3 tasks that I went through. Again, we're looking at these metrics: latency or processing speed, errors, and visual spatial accuracy or gain. We also incorporated various clinical measures just to compare the difference. And the analysis of this, it's, I won't get into specifics, but it's a generalised linear mixed model. Sorry. I'll just mention that we had 12 males and 6 females for this study. So firstly, when we look at self-reported symptoms, we can see that in general, athletes are recovering by the 7 and 13 day mark. But then when we compare this to various oculomotor findings for that antisaccade latency, that task where you're making a mirror opposite eye movement, the processing speed was following a similar trajectory as these self-reported symptoms, showing this transient change in cognitive visual processing speed. We noticed that this was actually only in the female cohort for this marker. But then when we look at visual spatial deficits, we can see that there is prolonged deficits in visual spatial processing. And this was evident in both the males and the females. So just to summarise, oculomotor assessment may be more sensitive at monitoring recovery compared to self-reported symptoms and other cognitive and clinical measures. So the second chronic study that I want to talk about, again, is looking at that pre-season baseline. So this was published last year, and it's an extension of a previous study in our lab. For this study, we had 26 footballers, and these were males with a history of concussion, asymptomatic males, and 23 controls. These were males that have no history of engaging in collision sport or no history of concussion. Again, we performed this oculomotor assessment using the prosaccade, the antisaccade, and then a increasingly cognitively complex switch task, which I'll go through in a second, as we found that the 3 tasks I talked about earlier weren't actually sensitive in this chronic cohort, so we essentially wanted to get a more cognitively complex task to try and look at these subtle cognitive deficits. And again, we looked at metrics of latency and error. In the study, we also incorporated white matter, a measure of white matter damage, DTI, and Meng will talk more about that. So this cognitively complex switch task, it essentially puts together the prosaccade and antisaccade task, is a measure of cognitive flexibility and task switching. So you'd be looking in the centre and you'd be making either a prosaccade or an antisaccade dependent on the colour of the central cross. So if that central cross was blue, you'd be required to make a prosaccade movement to that peripheral cross. And if it's pink, you'd be required to make an antisaccade movement. So again, it just adds that additional level of complexity. So what we found on the antisaccade task alone is that footballers had poorer cognitive processing speed than controls. So it took them longer to generate that eye movement. Then on our switch task, we found a greater magnitude of errors when switching from the antisaccade to the prosaccade task. And this is just reflective of poorer cognitive flexibility and task switching in that male footballer group with a history of concussion. Just briefly with our DTI findings, there was a significant correlation with reduced FA, that measure of white matter damage, and increased switch costs, and that was in the frontal areas. When we perform tractography and tract density, we can see that that tracks out to those frontal areas like the dorsolateral prefrontal cortex, which we know is involved in task switching. And therefore, it suggests that white matter damage may underlie this switch cost and poorer task switching in this group of footballers. So just an overall summary of my talk. For my acute study, oculomotor assessment may be more sensitive at monitoring recovery than self-reported symptoms and other cognitive measures. And oculomotor changes on cognitively complex saccade tasks in male footballers with a history of concussion were identified, and these may be underpinned by structural white matter damage. And now I'll hand over to Meng. Thank you.
Thank you, Georgia. So I'm here to kind of give you an impression of what this all means. And as a clinical neuroradiologist, I guess, and also from personal experience, if you get hit either in a car accident or concussed, and you go into the ED, and this happened to me in the prime of my life last year, during lockdown 64 in Victoria, when I went for a bike ride, and I fell off my bike. And when you go to the ED, at the most you might get a head CT, and invariably a head CT is going to be normal, right? So in moving forward with all of this, I think what we hope to see is that when you have a mild concussion or when you have a sports-related concussion, you might go to the ED, you might get an MRI scan, you get some blood tests done for GFAP and NFL, and then might get Georgia to come down and do some oculomotor testing. And this was actually on my mind when I was admitted to the ED, and they did a CT scan on my head, which is normal, obviously. And I said, maybe I should call Stu and Sandy and Georgia to come down and test me. Ideally, that's what we want to see, right? So, and moving forward with time, as more of this evidence becomes documented, we'll see that. So my role as a neuroradiologist, I guess we'll talk about that and how that'll factor into triaging patients. I also want to talk a little bit about some of the chronic findings in the same cohort, what happens beyond 6 months and 2 years, what happens to areas of brain that might atrophy, and what happens to your brain age. And then at the end, as a neuroscientist, kind of try and bring that together in terms of the pathophysiology. So why does this happen? And we think that there is a close relationship with genetics, with sleep quality, and what we call perivascular spaces. So these are the spaces in the brain that actually drain the fluid and clean your brain when you're sleeping. And they're most efficient and run most efficiently when we're sleeping. So it turns out that 14 to 40% of subjects that are concussed and have mild TBI already have predisposed sleep disorders. And then when you're concussed, that obviously gets worse. For those of you who recognize Floyd Mayweather, this is a boxer in the States. We were fortunate enough to take care of him and scan him. And excuse my kind of pseudo-American accent, but I did spend 10 years in the States and then 10 years in Los Angeles, where as a director of neuroradiology, we were asked by Russ, as the athletics director, he said, can you scan the men's football team at USC and compare them with the men's volleyball team? And we did this, and interestingly, this was ultimately funded by the NIH. And we found, much like you've already seen with Sandy, very similar changes. And you'll see those red areas in the brain in the corpus callosum. So despite the fact that we're looking at helmeted sports, and in Australian football and rugby it's non-helmeted, the injury to the parts of the brain are not dissimilar. And you might kind of think of why this might happen. When you're wearing a helmet, the kind of impact is more a head-on impact. There is some rotational forces, but in Aussie rules football, you tend to be tackled, and so the rotational forces and shearing injury happens where the brain's tethered, and that's in the callosum, so in the anterior splenium and the genia of the corpus callosum. So interestingly, that there's probably not a huge difference in terms of injury to the brain, whether you're helmeted or non-helmeted. So again, Sandy's already shown this, but really what happens to the brain beyond that acute phase? What happens to the gray matter? What happens to the white matter tracts? And again, this is the same cohort that Sandy has described. What we did was compared footballers with history of concussion with controls. And you might be able to see, so these are group-wise comparisons and measurements of the gray matter cortical thickness. And there are certain areas of the brain where you see highlighted in the blue, which show cortical thinning. And because the numbers were relatively small, we think that if there were greater numbers, and we're hoping that with the ongoing studies that Stu and Sandy and Georgia are doing, we'll probably see, again, areas in the frontal part of the brain, temporal part of the brain that really receive a lot of hits. There are areas of cortical thinning. And this also goes along well with the DTI changes. So again, we know that there are obviously acute changes in the diffusion tensor imaging. So diffusion tensor and fraction line isotropy, or FA, as George has mentioned, is really a measure of the axonal integrity of the white matter. So if you have the white matter tracts and axons in the brain, if there's injury, there's either swelling or potential demyelination or disruption of these axons, and this is what we think we're measuring. There is another process that's going on here called the perivascular spaces, which we'll talk about in a second, which we now know that also affects the radial diffusivity and the fraction line isotropy. So then, in terms of the imaging, we know that the chronic phases, there is abnormal axonal damage, and there's abnormal cortical thinning of your cortical gray matter in your brain. And this is consistent with some of the work that David Wright and again the Monash Trauma Group have done previously, the chronic effects of TBI in the rats. So again, showing some DTI changes as well as some cortical changes. So I'm putting my hat on as a neuroscientist for the last 5 minutes to talk about what we think is happening in the brain. So we think that there are probably genetic factors that might predispose you to have difficulty sleeping. So the ApoE4 gene has been closely related to dementia and Alzheimer's disease. We think in the second portion that there are issues with sleep. And if you're concussed, then your sleep is disturbed. I will show you a picture in a minute of the brain's perivascular spaces, which is the lymphatic drainage of the brain, which is affected when you don't sleep. And we think that all of this then goes and affects the brain blood biomarkers, so the blood biomarkers that Stu talked about, as well as the MRI scans that we talked about. And then in turn, this will affect your cognition. So we think that this is a process. I apologize, it's a busy slide, but this is probably the pathophysiology, or certainly one of our hypotheses as to what might happen in the brain. So what are these perivascular spaces in the brain then? So the brain obviously has lots of blood vessels to supply blood and nutrients to your cortex. So you see in the pink image, there's a blood vessel, and surrounding that blood vessel is what we call a perivascular space. Now these are critical for cleaning your brain. And when you sleep at night, the brain basically increases the cleansing of your brain by 2 or 3 times. And if you're awake, it turns out that the efficiency is reduced. So you can see on the top image how these black dots and waste products are cleaned by the brain, right? And it turns out that they go up to these CSF spaces and then they're drained into the neck. So there's a very nice paper in Nature Communications which showed that these lymphatics in the brain drain towards your neck. So patients that had neck surgery and so on will have impaired drainage. Importantly, and we've looked at 900 relatively young, similar to our football age group. As you age, the clearance of the brain is impaired, so the perivascular spaces become enlarged. With your BMI, there is probably more, adipose tissue in the neck, which reduces the lymphatic drainage. And obviously, if you have a bigger brain, you probably have larger perivascular spaces. Interestingly, in this study of 900 normal subjects, we scanned them, some of them early in the morning, and then some of them later in the afternoon. Later in the afternoon, these perivascular spaces become larger in the same subject. So in your brain, the spaces will become very small when you sleep because it's very efficient clearing. And then later on in the afternoon, they actually become bigger. And this is also very similar to a paper that we just published a month or 2 ago. And this is a study with NASA, the European Space Agency, and Roscosmos, which is the Russian space agency. We were asked to analyze the MRI data from probably about 40 astronauts and cosmonauts that spent 6 months in the space station. The controls were astronauts that went up to space for 2 weeks or less in the space shuttle, as well as some terrestrial humans that remain on Earth. You can see what happens in space where there's no gravity. Essentially, blood is pumped to the brain. It stays in the brain. The face is puffy. They get neuroocular syndrome, neuroocular symptoms, and the brain swells up. Right? There's impaired drainage. So what we found with these astronauts and cosmonauts is that compared with controls, these perivascular spaces enlarge after 6 months in space, which means that if you want to travel to Mars, which takes 3 years, well, you can't do it unless we figure out how to mitigate it. And some of the mitigating factors are maybe creating a centrifuge, or the Russians that developed this lower body negative pressure suit that actually sucks out the fluids from the brain. So this is what these perivascular spaces look like in the brain, and we developed some methods at Monash to quantify and characterize this. We know that in acute brain trauma, so in patients with post-traumatic epilepsy, there's asymmetry in these yellow dots, I guess you see in the brain. So in areas where there is some damage to the brain, these perivascular spaces become asymmetric. Gershon Spitz had been working with Jenny, who's familiar to you for many years. He, just to wrap up, looked at chronic traumatic brain injury, what happens to the brain. So he presented this at our lab meeting a few weeks ago, and he's working with our lab now. It turns out that the chronic changes over time results in brain volume loss in both the gray and white matter, and this results in what we call advanced brain age. So age, even though you may be 30 or 40, your brain age is quite a few years older because of the volume loss. So he was able to show this, and this also correlated with some cognitive testing, and interestingly, some sleep disturbance. More recently, Gershon has analyzed the perivascular spaces in the same group of patients. This is not published data, obviously. So if you take a picture, I'll have to kill you. But he also showed that, interestingly, the perivascular spaces in the same group of subjects that had advanced brain aging were enlarged. And so this is something, obviously, we're very keen to work at. And then finally, so if you're a patient and you came in and when you did all of this perivascular space imaging, DTI, cortical imaging, this is some work at USC that we had been doing. It's called a brain connectogram. So you really want to connect everything together, not only the imaging, so the yellow, the colored coordinated areas are the cortical areas that are pastellated. The lines joining the areas of the brain are the DTI, and then the functional connectivity. So this is a connectogram of a brain's structural and functional connectivity. So then, if you then apply something like deep learning and machine learning to add on the blood tests, the blood biomarkers that Stu talked about, and then the oculomotor tests that George just talked about, we can create like a personal map or connectogram of your brain to determine how functional it is. And just to give you an example, on the left is a footballer who's concussed. On the right is a control. You can see that the connectogram after you've been concussed is severely diminished. So we're kind of doing this now for potentially things like dementia and TBI. So I'm going to finish there and hopefully giving you an idea of what happens chronically in the brain, where we're moving in terms of more advanced brain imaging, the perivascular spaces, and the pathophysiology. I'm just going to hand over to Sandy and I'll just to summarize, and then we'll have some time for questions at the end. Thanks. Thanks very much.
All right. So I know we've thrown a lot of information at you today, and so I thought it would be nice just to spend a few minutes to quickly come back to those knowledge gaps we identified early on and try to tie things together. So first, in terms of, can we reliably and objectively diagnose a concussion? Essentially all the modalities we presented today are able, in some capacity, to identify abnormalities in kind of the first 24 to 48 hours after a sports concussion has occurred. And as Stu alluded to at the end of his talk, I think now we're kind of in that space where we're honing in and determining exactly what biomarkers or combination of biomarkers at what time are the most appropriate. And then obviously there are still hurdles to overcome in terms of getting these into application, whether it's TGA approval or other issues there. In terms of when is the brain recovered and when is it safe to return to play? Again, on our self-report symptom measures and other kind of commonly used cognitive tests, we see that at a group level they're recovering within the week. On the other hand, when we look at blood biomarkers, MRI, ocular motor measures, on some of these measures we're seeing that they're persisting to 13 days, and in some of the new results that Stu's showing, well beyond 13 days. So obviously it raises questions pertaining to what recovery time should be mandated, whether mandates are required or whether or not we're able to advance to a personalized approach where we don't have these, group measures applied. And so that's one of the key hurdles to overcome in that space. In terms of the long-term repercussions, again, Meng presented results from our work showing changes in the brain, both in terms of cortical thinning and the white matter integrity. Georgia also showed some findings where there's some cognitive ocular motor abnormalities. This all aligns with research going on around the world that is also finding evidence that there are these long-term repercussions. And there's growing research from other groups in Australia that are identifying this as well. So, we're coming to a place where there appears to be agreement that there are long-term issues, and now the question becomes, how do we mitigate some of these consequences, whether it's through guidelines and management protocols that require longer return to play, where people's brains may not be vulnerable, to whether or not there's pharmaceutical interventions or other kinds of interventions that can help with recovery. And then in terms of the sex differences, in some of our smaller studies, we are seeing that there may be differences between the sexes, but on the other hand, as Stu presented, when we get into larger sample sizes, it looks, at least on some of these markers, that they can be applicable in both men and women. And that, again, holds true in some of the other larger studies coming out in North America, where, at least with the blood biomarkers, there are quite similar effects in the men and women. So I will leave it at that, and hope I've left a few minutes left for a few questions from the audience. Yeah, I don't know if there's a mic.
Hi, I'm the mum of a young woman with a severe traumatic brain injury, and on a couple of occasions when she's had a knock to the head and we've presented her at ED, and the doctors just look at us and go, well, what do we know? And I go, well, I want to know if she's got concussion, and they say there's no way we can tell you that. Will these blood biomarkers be able to confirm for sure that she does or doesn't have a concussion? Because it's just been that having a severe brain injury, there are occasionally falls or bumps, and never have they been able to give us any answers.
Yeah, I'll maybe comment quickly and then hand it over to Meng for his clinical perspective. But yeah, I mean, that's a different scenario than what we're talking about here. What you might have seen on some of the spaghetti plots that Stu showed, it very well may be that in your case there are kind of elevated baseline levels, and then it becomes the question of whether or not our methods are then sensitive enough to identify, I guess, more subtle changes in terms of the more severe brain injury that has occurred. But with that said, if there was a baseline measure, that may be much more feasible. But again, for this, important point to note is that at the moment these blood biomarkers aren't used in the clinical setting in Australia. Hopefully in the coming years they will be. They are used in other countries, so it is feasible. But maybe if
context, so that you basically triage people that need to have a CT, so a couple of them are. But I think what our data showing there is that even when you focus on those who don't have a CT abnormality, which is the vast majority of cases that Meng sees, that we do actually see changes there. So that's sort of a point of difference with our research, is that we have that sort of hidden injury in mind with this research, yeah. Yeah, well, I think for the sports stuff, for example, and any injury, having a baseline is a good starting point. But what we're now doing is trying to work out normative ranges for people of different ages and sexes and whatnot. So then we can identify when an abnormality is present. And I think we're getting closer. Meng, did you want to add to that?
No, I think that's right. So yeah, I mean, obviously still in the research realm. Similarly, for MRI scans are not available for everybody that comes into the ED. But eventually, like in the States, there are 2 or 3 football teams that have an MRI scanner in the stadium. So eventually, when it becomes more accessible, if you fall, we can do a DTI and figure out that you've had some concussion.
So congratulations, you're doing great work. It's good to see such team collaboration. Look, my concern is this, that it's such a subjective condition, concussion. And you've all shown great work, but you've also shown the inadequacies of what you're doing, i.e. the biomarkers, the MRI findings, the inherent inaccuracies of DTI, the oculomotor tests, and the fact that many of these people have impaired cognition even before they have their head injury. Look, what are you going to use as your gold standard? I mean, it's not dissimilar to the concept of pain. And, you know, someone has pain, you do all these tests. I'm sorry, you don't have pain. There's nothing structurally wrong with your back. None of your inflammatory markers are elevated. I'm sorry, you don't have pain. But the patient clearly has pain. It's like concussion. These people have problems after their head injury, and yet some of their biomarkers, and you've shown this very nicely, may be completely negative, like that group of females, for example. What are you going to use as your gold standard? Like, with me, it's simple. A brain tumour. You know, if someone's got a brain tumour, they've got a brain tumour. And then we're trying to find out all these other blood tests to try and diagnose brain tumours based on assays. But at least you've got a gold standard. You know that they've got a tumour. What are you going to use as your gold standard to make the diagnosis of concussion?
Yeah, that's an excellent question. So good thing it's lunchtime now, Charlie, so we have to go to lunch. But if we had 3 hours, we could have a discussion about that. But that's a very valid question. And I think, you know, perhaps I was thinking as you're asking that, that each individual is their gold standard, and they start off, and you know, we get a baseline of what their overall brain scan looks like, and what their bloods look like, and you know, there'll be a range for different ages for your GFAP, NFL, and then if you get concussed, if we see a variation from your own individual baseline, then you know, maybe it's significant, but you know, it's a very complex question. Yeah.
It's a really important point, that it is a clinical presentation, so that's how you're defining it now, which is why we recognise there's a need for these objective measures to help. So I guess what we're thinking is that these tools will provide that neuropathological basis that we can go beyond just saying there's concussion or not. There's actually presence of diffuse axonal injury or you know, other changes that we're seeing there. So, but it's certainly a factor that when you don't have a perfect gold standard, assessing the accuracy of any test is difficult. Yeah.
Thanks. This is just a comment. I'm a rehab physician. The most interesting thing about, well, there's a lot of interesting things about the research you're doing. It's very wonderful. Is the length of recovery, the long tail of changes that you're seeing, and also the sort of chronic accumulation in these players. It's very sobering, but I think it's also an amazing window on how the brain works and what helps it and what harms it. And so, yeah, so it's really just a comment. I just think good on you, keep going.
On that note, I'd like to thank the Monash Trauma Group, Sandy, Georgia, me and Stuart for presenting today. Thank you so much. Hopefully they'll join us for some lunch and you can ask them questions during lunch. So thanks everybody for attending and thanks to our presenters.